if we haven't already. Perfect, thank you. So today's agenda is going to include some introductions and brief announcements, a didactic presentation focused on building patient trust, particularly in youth and their families, by Dr. Alfaro Cruz, and then we have an adult case presentation and some time for Q&A and a little bit of an interactive type of slides as well, and then some brief closing remarks. First, let's start with some in-chat introductions. So if you will put your name and organization and role and whether or not this is your first echo into the chat, it would be great. And feel free to turn on your cameras so we get to see your faces and know you. And while we are doing that, next slide. A few quick reminders that I just wanted to highlight as we're kind of joining this session here is to make sure that we're registered for the correct event. So you can use the QR code or the link there to make sure we're registered for this event, and that's going to help ensure that you receive the appropriate emails for the evaluation and the continuing education credits as well. Next slide. Please turn on your video and mute yourself unless speaking, but feel free to come off of mute at any time and ask questions and interact with everyone. And it doesn't look like anyone has joined by phone that I can see. So I think we're good there. And a few other quick reminders just to never discuss PHI and of course treat everyone with respect. And then we can go ahead and get started with our presentation. As I said, which will be about building trust between providers and clients. And so I will pass it off to Dr. Alfaro Cruz to get us started. Dr. Alfaro Cruz.
Hi, good afternoon, everyone. Thank you for joining us today. I'm going to talk about building trust between providers and clients, focusing on our pediatric patients and young adults as well. Next slide, please. So I have no conflict of interest to disclose. Next slide, please. So my objective is that at the end of these sessions, we're able to understand the importance of the doctor-patient relationship applied to the pediatric patient, identify strategies to build trust with patients, recognize the importance of the pediatrician-patient-family relationship, and understand some of the challenges of adolescents in health. Next slide, please. So let's start by defining the doctor-patient relationship. And that is usually defined as a consensual relationship in which the patient knowingly seeks the physician's assistance, in which the physician knowingly accepts the person as a patient. Now, at its core, this relationship will be consensual, and the physician will agree to respect the patient's autonomy, maintain confidentiality, explain treatment options, and obtain informed consent with the goal to provide the highest standard of care and commit to not abandon the patient without giving him or her the adequate time to find a new doctor. So that's kind of the known definition or the formal definition. Next slide. But when we talked about that relationship, that definition, it's very not, it doesn't encompass everything that it actually happens. And because this is a unique relationship that will have 4 key elements: mutual knowledge, trust, loyalty, and regard. When we talk about knowledge, it refers to that doctor's knowledge of the patient as well as the patient's knowledge of the doctor. That can go from where the doctor trained, what do we know about our patient, what are the studies that our doctor has, or what's his or her niche in medicine. Now, when we talk about trust, this will involve the patient's faith in the doctor's competence and caring. as well as the doctor's trust in the patient and his or her beliefs and report of symptoms, as well as if they're compliant to medication, right? If they're following instructions, and how they trust both of each other in the relationship. Loyalty will refer to the patient's willingness to forgive a doctor for any inconvenience or mistake that the doctor actually commit, or that loyalty of the doctor to not abandon the patient despite problems in the relationship. And then regard will imply that the patient feel as through the doctor likes them as individuals and is on their side. It's regarding the empathy and feels that the doctor is an ally in the battle that they are having regarding their health. So these are going to be the 4 elements that are going to be basic on the doctor-patient relationship, and that will be actually working throughout the whole process. Next slide, please. Now, where does it start? We talked about trust and we talked about loyalty with our patients, but let's start with trust. So this is essential for that relationship to work. And these can actually be affected by the actions or inactions that us as clinicians will make in this. And so high levels of trust can support confidence, peace of mind, and a sense of security among your patient and the physician. But broken trust can also happen, and that can lead to anxiety, second guessing, frustration, and even failure of treatment. Next slide, please. So last week, we talked about building trust with the adults, and it's actually very similar when we talk about the pediatric patient. But in this case, when we're talking about building trust, we're not only building trust with our families, we're also building trust with that small kid that is coming to your clinic or even that adolescent. So how can we build trust among our patients? Be true to your word, honor your commitments, and don't make promises you can't keep. That is one of the first things that they teach us. Don't ever make a promise if you're not able to commit for that. You need to know that you don't have to lie to your patients. You need to be consistent about building trust and telling them exactly what to expect. You need to communicate effectively. So once you have to be clear about what is happening and what will happen. You have to use common words. That is something that it's important, not use medical jargon. There are studies that says that health literacy in our country, it's actually between the 6th and 8th grade reading level. So when you're trying to communicate effectively with our patients and with our families, you have to make sure you use common words. And you have to make sure everything that you give them, they provide them, even if it's handouts, they have to be at their reading level, because that will actually make the relationship work better in the end. You have to build trust gradually. This takes small steps. Don't expect too much too soon from the patient or from the doctor either. You will build this relationship across time, but don't expect that the first day that they meet you, they're going to completely trust you. Trust will be gained from both sides. Make decisions very careful, especially because you have to take into account that these diseases are chronic, and these diseases can be actually related to other stigmas that can affect them as well. So it's important for you to be carefully talk to the patients regarding what will be the treatment, and also have the courage to say no. If you think over testing or giving treatments that are not within your scope of practice and they won't do any good to the patients, be able to say no to that patient, knowing that they should trust you because you actually have investigated thoroughly this. Participate openly. Show willing to trust, listen actively. The patients, a lot of times, especially in families, the mom knows always if something is happening with the kid. So listen to her. When she says something is happening or something is not good, ask her why and ask her to give feedback, and that will actually improve the relationship. Be honest. And I think this is one of the most important ones when we're talking about building trust. Never lie. Always tell the truth. Even if you think that may actually create a gap, be honest. That will be especially important when we're talking about long-term treatments with consequences. Help people. So this is something very important that as providers, we need to take into account. You need to be able to help, especially when there are occasions where you actually can be a support. They are navigating a world of insurances, of medications. So try to help them. Ask them what can you do to make the situation easy? And that will definitely come up and build in trust. Show your feelings. Be empathic with the patient, right? That will definitely open up for them to see someone that it's close and give to the relationship of their patients. And do what you believe is right. We talked about honesty. We talked about that people that always say yes does not mean entirely trust. So do what you believe is right. If you think that a medication may affect the patient, or if you think that some treatment, speak up and say, I think this cannot be done because it can actually hurt my patient. And another thing that it's important and goes with honesty is admit mistakes. If you make a mistake, say so. We are always taught in medical school, primum non nocere, right? And so if you made a mistake, the important part is to disclose that mistake. Different studies have shown that physicians who actually make mistakes and disclose them have a better relationship with the patients and are also less likely to get sued because of admitting their mistakes. Next slide, please. Now, this is a trust dynamic process. And this chart right here will show you how this process of trusting a physician and building and maintaining a relationship goes about time. So this model that calls for increased attention to the relationship over time, because sometimes we think that it's just that first appointment, the patient actually will start trusting us. But actually, there can happen so many things during the process of treating a patient and managing a patient that will actually affect how credibility and trust goes around. You need to make sure that you know some of the cultural background of that patient. And I think we discussed that last week when we talked about that there can be sometimes so many cultural processes that can change how we address a patient or what they think about certain diseases. So knowing about that will give you some of the basis to start building that trust. At the beginning, pretty much what the patient feels about the institution where you work or previous experiences with doctors may actually change how much he trusts you or how much he thinks you're credible for them. But that is something that you'll have to kind of show him with time, that even though he may have had bad experiences in the time, that doesn't mean he's going to have one for you. But it is important to know that that still can happen there. And that can definitely affect how we're going to be trusting our providers and our families with time. Now, remember, during this timeline, we are seeing that you will build trust, you will maintain trust, and that will be working through. But you can also break trust during that process, right? And that breaking of the trust will actually cause for the patient to have lower trust and lower credibility in you. So you'll have to work on rehabilitating that relationship by talking to them, by having open channels of communication and receiving feedback. You can demonstrate that by showing honesty, competence, caring, and then fidelity with your patients. Next slide, please. So I mentioned building trust. But then what happens when we break trust? And some of the most common examples that they ask some of the patients of why they stop trusting their provider are shown here. And as you can see, one of them is, I wasn't upset by my child's bad reaction to the treatment. I was upset because no one told me it was a possibility beforehand. Another example of breaking trust or things that can actually get to break trust is, I don't think our doctor looked at us during the entire visit. She just kept typing away. And the third example is, I couldn't get in touch with my child's medical team for 3 days after the scans. I just had to sit around and worry until the nurse finally returned my calls. And so even though these are small things that can actually break trust, they are important for our patients. And so despite the good intentions that sometimes we can have as a provider, and we know that we are busy trying to take care of a lot of patients, sometimes just doing some eye contact, listening, making sure they feel that they're listened can change the relationship when they are in the clinic. Now, it's important to know that these errors of communications are usually the things that are most commonly displayed as reason why it was the trust was breaking. When trust is diminished or broken, the clinician should take steps to reestablish that credibility and rehabilitate the relationship. Again, these efforts would ideally take place before the crisis, right? But breaks in trust might not become apparent until the relationship is strained by clinical circumstances. Now, clinicians in these situations are actually recommended to borrow concepts from the conflict resolution literature to realign with the family. And that literature always suggests that communication efforts should be focused on identifying what's the family underlying interest, seeking the truth, and recognizing anger as a reactive emotion, and that we can change that as well. Next slide, please. So when we talk about that relationship, and we're talking about you're not only building a relationship with a child, with an adolescent, you're also building that with mom, with dad, or the grandparents, or whoever is the caregiver of that patient. You have to prioritize open channels of communications, and that will definitely build trust and improve care. Most of the time when we have patients who are in foster care, and they have access to parents on both sides, you have to communicate with those parents as well. You have to communicate with the foster parents. You have to communicate with the state, but make sure everyone is on the same page. Now, we said families should always receive information in a format they can understand, and health literacy plays an important role in this. You need to make sure they understand and have open question formats for them in order for them to comprehend what's going to happen and what's the diagnosis and what's the treatment. Family needs to feel that they can act on the information given. They need to make sure that they are part of the treatment team and not just receiving orders from the providers. You need to talk to them about all side effects, about interactions, about possibility of what can happen. And they need to feel like they have a choice. And in the end, they can decide what's better for the kid. Be transparent about the decision-making process. Now, sometimes, as we say, if you don't know, it's okay to say, I don't know. It's okay to say, let me actually go in and investigate more about that, because it will actually make the process better regarding the patient and relationship with them, and show empathy. A lot of these parents are actually suffering, are scared, not only because of their child, but because they don't know what's going to happen. So try to show that empathy no matter what. Take a minute to actually talk to them, look at their eyes and say, okay, how can we manage, or how can we improve these? Next slide, please. So once we talk about the general relationship between that patient and family, we need to think a little bit about the adolescent, right? And this is the definition from the World Health Organization, that it says that it's the phase of life between childhood and adulthood, from ages 10 to 19, and it's a unique stage of human development and an important time for laying the foundations of good health. Next slide, please. But that's just a definition that WHO presents for us. But actually, adolescence is a very challenging period. And it's a period where we are actually achieving biological and sexual maturation. We're actually trying to develop our personal identity, where they actually will start with development of intimate sexual relationships with appropriate peers. And they will establish of independence and autonomy in the context of social cultural environment. Adolescence is that period where you don't know what is happening, but you know there is a lot of changes going on. They start to think about it, how much ownership they have on their own body, how much decisions they can make, and they start discovering their personal identity as well as their sexual identity. So this is actually one of the most complex periods in the life of anyone, because at the same time, you have a parent that is taking care of you and is taking still decisions, and legally you're not allowed to get decisions on your life. But at the same time, you start understanding more of these processes. So next slide, please. So it's important when you're talking about building a relationship with the adolescents that you start creating a relationship with them as well, not only with the parent. And you're going to see that change when you're following patients from when they're 1 year old and they just start becoming older. So you have to start seeing young people by themselves as well as with their parents. Do not exclude parents completely. And that's actually very important to understand about this relationship. But make clear to the dad that the adolescent is the center of the consultation, that he will express his concerns or her concerns, and that is what we're focusing around. Do this writtenly as a way to respect their healthcare rights, and families should receive information also, as well as the adolescent, in a way that they can understand. Be empathic, respectful, and non-judgmental. Remember that when you're discussing all these behaviors about substance abuse, about sexual relationships, they want to make sure they're being listened without actually being judgmental or being afraid that it's going to get disclaimed to the parents or to any activities. So make sure they know that. Assure confidentiality in all clinical settings. Something that is very important to talk to the adolescent is that whatever they disclose confidential with you, it stays confidential. A lot of the time when they want to disclose that they are having unprotected sex, or they're concerned about being pregnant, or they're concerned about using drugs or alcohol, they need to be sure that they can trust you and bring confidentiality into the table. Another thing it's important is be yourself. Don't try to be cool. Don't try to be hip. Young people want you to be their doctor. They don't want you to be their friend. We have multiple generations right now. We have boomers, we have Gen Z, we have Gen Y, we have millennials, we have Generation X. So all these generations maybe will not share a point in time. So these kids know that you are not someone from their peers. They know that you are a doctor, and therefore they want to have that relationship with you. They're not looking for a friend, but actually a doctor that they can trust. And then try to, when you communicate with the adolescents and explain concepts, don't talk about abstract concepts like the future. Talk about here and now. When you talk to them, when they come into the room, talk about what are we going to do today. Don't start talking about if this happens or if this test is positive, then in the future will we do or this. No, because they are not seeing the time as future. They're not thinking about that at that time. So when you talk to them that first appointment, just focus on the here and now. Sometimes you may have to go into full detail and get more like a adolescent psychosocial history. Talked about home life, talked about education, activities, drug use, sex, if they have any suicide ideations, or if they are depressed, how they're sleeping. But you have to be careful in order to approach those, assuring always confidentiality. And that will only be if you feel appropriate that you need to take a full adolescent psychosocial story. Next slide, please. So now we're talking about adolescents, right? And I mentioned that we should not exclude parents completely, but parents also need to understand that it's time to give the kids some privacy as well. But there are actually studies that show how we as primary providers or as healthcare providers, we can actually help the relationship between parents and adolescents. And these studies have shown that those who maintain a better communication with their children, that spend more time together, that they talked about academic expectation, where moms are actually putting more discipline in their children, and they show parental warmth, where they can feel, I can trust my dad, I can talk to him about things. These kids actually will have better health outcomes as young adults. Investment in improving this relationship should be important, and actually will have substantial benefits in how those young adults health outcome improves. We have seen that and it's interesting in this study where actually the moms were the one that were putting more discipline in children, they actually had more successful young adults regarding commitment to work, regarding responsibility. So your mission is not to be the referee between parents and adolescents, but your mission is to fortify that, making sure you have open channel communications between parents and the adolescents, or parents and kids. And that will actually build foundations for better health outcomes as they grow. Next slide, please. So any questions up to this point? I think we're going to do an echo pause.
And you can put your questions in the chat or come off of mute, and feel free to ask your question as well. Okay. So I really appreciated, Dr. Alfaro Cruz, that you mentioned really so many different things in here, talking a lot too about not being afraid to mention mistakes and communicating directly with, an adolescent individual. And instead of, it's really easy to kind of fall into a pattern of talking to a parent. And sometimes you can have a really eager parent that just wants to do a lot of the talking anyway. So that was a really great point to even, speak directly to the child. And even a lot of really young children, I've seen, providers, 8 and 9 and younger children talking directly to that child and interacting with them and making them feel a part of it. So I really enjoyed hearing about that and kind of being able to take some of that to our own practices as well. So
And I think it's important that those communication cues, actually, where we think the adolescent or the child is not paying attention, they're actually paying attention. They do prefer a doctor that looks at them instead of just talking to the dad. That when you ask questions, you're looking at both of them, because that actually will get them to open up to you, speak more about the issues that they want to talk, and then get a better rapport relationship with you as well.
Yeah, great point. I really appreciate that.